Thank you, everybody, for joining us. We have the lovely Dr. Sheila Morrison and Dr. Roya Habibi here today to talk about modern scleral lens fitting, demystified technology versus traditional fitting. Let's kind of go briefly over bios here. Dr. Morrison earned her doctorate of optometry and completed a master's degree in vision science with a focus on scleral lenses, along with a residency in cornea and contact lens from Pacific. She served on the faculty for the University of Houston College of Optometry, facilitating education and research in the contact lens and cornea service, and currently is up in Calgary at Mission Eye Care Center, where she is the co-residency supervisor of the cornea and contact lens department and adjunct faculty at NSU, Oklahoma. Dr. Roya Habibi received her doctorate of optometry from the University of California, Berkeley, and completed a medical contact lens fellowship at Casey Eye Institute. After completing all of that, she joined a group practice in Seattle, where she developed and launched the Center for Eye Comfort, full service dry eye center. Also as lead provider for the Seattle Cancer Care Alliance's chronic ocular graft versus host disease, providing advanced care to those long-term patients, and lead investigator on their clinical trial testing allogenic serum drops as a treatment for ocular graft versus host. Then, after many years in Seattle, she has decided to move her family to Tamarindo, Costa Rica, where she opened a concierge eye clinic. In her free time, is the host of one of the top eye care podcasts, Try Not to Blink. Great podcast. Both these ladies are on.
Yes.
Our financial disclosures here. As for CE credit, you guys, anyone on here, again, you have to stay the 50 minutes, will receive your certificates about 2 to 3 weeks after this. Reach out if you don't. Throughout, we'll do questions at the end. So after about 15 minutes, we'll kind of open up to our lovely speakers and ask those questions. So you'll just kind of put it into the Q&As and we'll get to those at the end. Before we pop in, just a sneak peek at what's coming up next. Next month, we'll be going over clearing the surface corneal management of non-keratoconus cases. Dr. Pooja and her brother, who is a corneal specialist, will be going into that topic. So mark your calendars. We're receiving that soon. And without further ado, I'm going to turn it over to Dr. Morrison and Dr. Habibi. Thank you, ladies, for joining us.
Well, thank you so very much for having us. It's kind of one of those things. We love the Scleral Society. Roy and I have both been involved over the years, and it's just our pleasure to be here. And the topic we want to share with everybody is called Modern Scleral Lens Fitting Demystified. And really what we're after is to kind of give our clinical perspectives. We have kind of diverse backgrounds, and we wanted to kind of play up on that a little bit in kind of a sort of a mock kind of somewhat debate throughout some of this lecture so that we can share kind of our clinical perspectives of how traditional fitting of scleral lenses and technology-driven scleral lenses sometimes differ, and also how everything kind of merges together. Now, my disclosures here, I'll just kind of go through. So this is me, you've already had my bio, and here's Roya. I'll let you kind of take over from here.
Yeah, so kind of like Dr. Morrison mentioned, we both have very diverse backgrounds. And what we really want to talk about is how we practice different and how we maybe learned a little different, but how we still are able to service our patients in an excellent way. So without further ado, we'll go first to talking a little bit about the trends, okay? So we won't spend too much time. Most of you know this, but there's obviously an upward trajectory in fitting scleral lenses. We know that from the SCOPE study. There's an increased number of people or doctors fitting scleral lenses just in the past decade, and the increase in utilization of fitting scleral lenses even in the past 10 years. So this table down here actually shows the number of patients with keratoconus that were fit in scleral lenses. Now, less than 1% seems very small, but this is obviously a survey, but it's gone to 22% in just 10 years, which is really, really awesome. So anyways, next slide, we'll talk a little bit about the education.
It's
Sheila?
something that's been like so crazy, hey? Like over the years, I mean, we used to, I would say, largely be kind of limited to several key like opportunities throughout the year of like a conference or something like that, or a workshop. Now it's almost like there's education. We like to showcase some friends on here, some wonderful resources and places, but online CE has really exploded. And what that means for us is that we really have more opportunities than ever to learn kind of the insides and outs of fitting sclerals and how we can really optimize care. So it's no longer just kind of the basics, but how do we elevate and do things to the highest level?
Yeah, if you want to know, you can learn. Like whatever topic it is, whether you're a beginner to advanced, it's available, which is awesome because when we were starting, that wasn't available. You couldn't, it was a lot harder to be able to get into the field. Obviously, there's benefits in utilizing scleral lenses. Anyone who's listening to this knows it, regardless of how much your fitting lens is. But of course, there's an increased reach of the patients that actually get the advantage of wearing scleral lenses. Standard of care often has changed. It kind of blah, 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 has
Blah, blah, blah.
improved. Tech, of course, is improved, which we're going to touch on.
We'll
And
touch
then,
on
of
that
course,
just a little bit. Touch on.
right. Then the decreased need for complex surgeries. I mean, obviously, we love to be able to avoid a patient having to get any sort of, vision threatening surgery and life altering surgeries. So the scleral lenses, as we know, is such an amazing tool, and it's grateful to be able to have this option. I'm going to show one more little graph right here, the indications for utilizing scleral lenses. I mean, we all know, of course, corneal irregularity, and in that category falls keratoconus and, post-graft scars. But ocular surface disease has increased pretty significantly over the past 10 years. Uncomplicated refractive error has stayed about the same, but we're using scleral lenses for more things and more often and more people, which is awesome.
Yeah, I really like the point about, decreasing need for surgeries because that's like, when somebody gets a corneal transplant, we know that tissue really has a finite life. It's not something that's going to be with them for the rest of their life if somebody in their 20s or 30s has a surgery. So, yeah, that increased use of sclerals over time now has really offered benefit to patients in all kinds of ways. Now, with increased use comes a big responsibility. And
Of
so kind
course.
of play up to our kind of, what good cop, bad cop, there's a risk as we increase the use of any medical device. Fitting people in, 1 out of 100 had a problem. Now we're fitting 200 people. That's 2 people that could have a problem. And so when it comes down to our responsibility, that is something that as things become more readily available, education opportunities are greater, we have access to products easier across the border, no problem. There's still some things we need to think about. In fact, in the clinic, I don't know about you, Roya, but there still is really no set standard across providers for handling and care. I think part of that is because every patient is their own unique fingerprint. We can't just put like, okay, everybody needs to use this solution, change their lenses at this time, because it's not black and white like that. But at the same time, without a set standard for the use of a medical device, and that's what scleral lenses are, sometimes there can be confusion for our patients, and that could possibly harm them.
Totally.
Some other things to really think about is as we all become more and more comfortable with sclerals and, being new to fitting them is a wonderful thing. It does not mean that it's a bad thing that it's your first 5 fits this year, no problem. But that is also part of the responsibility and understanding that there is a range of expertise of fitters out there. Patients, who have formerly been told they can't be fit can be fit now easier because of technology. And, really fitting sclerals, and it goes for all different modalities, I would argue. Ortho-K has become easier to fit in some ways because of technology and digital scanning, empirical design. But at the same time, especially with sclerals, when we're fitting on vulnerable populations, like check out this eye in the photo. This is a patient who had a traumatic injury. He has traumatic glaucoma, really prone to edema. This guy is typically a hot mess every time he comes in the clinic. So fitting sclerals can be really easy to get the lens to actually sit on that eye. But until you start to see complications, things can it's easy until it's not. And so that would be a risk that I see of increased utilization of scleral lenses.
That's a great point. I mean, when you do see an eye like that picture you just showed, Sheila, if you really look at where the scleral lens is hitting, it's not going to be that hard to fit a lens over that eye. But
Totally.
you really have to um, pay attention to your follow-up, right? Like pay more due diligence to following up because a patient lost to follow up with an eye like that is far more dangerous than a patient lost to follow up perhaps that has keratoconus. Not to say we want
Exactly.
on either of those lost to follow up, but anyways, let's get to the fun.
Without further ado.
Yes, without further ado, fun stuff. We're going to talk a little bit about some of the advancements in scleral lens fitting technology. And first, we'll just do a little intro. I want to do a little kind of a timeline, if you will, on mainstream fitting techniques of scleral lenses. So we know they started around 1880s. The first scleral lens was produced. They were made of glass. They've changed materials. We mostly were using our slit lamps and our topographers for fitting, but only in the past 10 years have things really started to change. Anyone who's listening to this lecture that graduated around kind of when Sheila and I graduated back in 2014, 2015, the way we were taught and educated on fitting scleral lenses has dramatically changed in an amazing way just because of how much technology is now available. So in 2014, impression-based scleral lens prosthetics were introduced, which kind of incorporated the 3D analysis of the fit using something other than these hypothesizing ways and techniques of fitting lenses. Then in 2016, the scleral topographer was introduced, and that's now really allowing us to analyze what the scleral lens or sclera looks like so that
Already
we
been
can best.
it's been a decade.
It's
Sweet.
crazy. Yeah. I mean,
Yeah,
it really
things have
just
changed.
it's fascinating if you talk to someone who trained before or after, because
Yeah.
the scleral topography, would you say, Sheila, it kind of seems like a mainstay in how you educate on fitting scleral lenses nowadays,
Well,
as opposed to.
there's so much benefit to understanding shape. So yeah, no, you're hitting it. I'm totally resonating with what you're saying.
Well, and I'll say, to be fair, like at my school at Berkeley, we didn't, scleral topography was still in research phase. So there was nothing of that nature. I did my fellowship in 2015. We didn't have a scleral topographer then. We had a Penacam, but CSP was far from, not to say brands, but there were other brands that came out with topography methods, and it was far from being available at the time that I was learning. So I never actually learned, even in a fast-paced setting, how to fit with those lenses or with those technologies. And then if you fast forward to 2019-ish, then we started increasing our technology to provide even more visual acuity and visual assessment, which is, we'll go a little bit more into detail for that, but really has allowed us to take this piece of plastic and make it something way more than what we could have ever imagined it to be. So if we go to the next slide to go a little deeper on impression-based fitting. So for those who are not familiar with impression-based fitting, there's one, correct, Sheila, one main company that does this at the time. And essentially you're using a kind of like a dental goo, we'll say, or a dental material to create a mold of the front of the eye. That mold is then sent to the lab for 3D scanning, and then a lens is produced based off the shape. And you're able to make very, very finite adjustments based on the analysis done from the actual shape of the eye. So it sounds amazing in theory, and it is really an amazing technology to be able to be used. But of course, it has its flaws, which leads to kind of some of the next ways to analyze the data.
I have to pay homage to some of the groups that before ocular surface topography or pardon me, profilometry came out, and that sort of digital mapping that you had, but I think you said in like, what was it, 2019 or no, 2016. You know, there are groups that have been using OCT, for example, like Greg Gamols, the folks at Pacific, a bunch of other institutions, really to image ocular shape. And so the era that we're in now, these are some examples of different types of tools that have a little bit higher or a newer way of imaging the entire ocular surface to really get a good idea of what that shape is. So we have corneal topographers, profilometers, tomographers, anterior segment OCT, and tools that combine all of the tech together to really create many different ways that we can understand ocular shape to make lens decisions. And we're going to go through a bunch of that throughout this lecture. Now, wavefront is something that I know Roya and I are both really excited about these days. And I have to say, as much as this Costa Rican goddess is our traditional player in this game. She has actually, you've been an early adopter. In fact, I think you started working with aberrometry earlier than I did, doing some beta testing. And it's kind of a neat story. When this technology started to become a little bit more mainstream over the last 5 to 10 years, it started off in our practice of, me sending patients down the street to the cornea specialist where they had an eye trace, which was an aberrometer that was not hooked up to any contact lens software. We'd have to download all of have them fiddle around, do their magic to try to create, a lens that could correct the aberration. Now, today, on the right-hand side is an example of a tool that has allowed us to integrate the technology of measuring for higher order aberration and wavefront technology into a device that can actually connect with contact lens manufacturers directly in a way that is streamlined, organized, easy to use, and very patient-friendly. And we'll show some examples of how that technology looks when we're explaining things to our patients.
Yeah, like just as a like kind of a summary of what you just said, a lot of times you'd have to get the data and then you send this like very big, think of zeros and ones to your lab to try and analyze that information and then build a lens, as opposed to the newer technologies actually analyze the lens plus the wavefront information and
Yes.
then send a recipe to be made so that the labs don't have this like crazy analysis to do, and then the patient gets what we predict, which is really really cool. So we'll kind of talk on that in some later slides. But what we're going to do today is do a little bit of a what's the best way to fit the lenses. So we like to say it's a little clinical showdown. So as we've alluded to, I'm going to kind of be the advocate for sort of the traditional artistry, while Sheila's going to be our tech all-star. So you can kind of see some of the things that we've used, whether currently or in the past. But just a little thing I'll say about myself and then Sheila is I practiced without learning on scleral topography, without learning on anterior seg OCT for analyzing lenses, and ran a very, efficient clinic. Back in my Seattle days, I was seeing 20 plus patients a day, fitting, hundreds of patients a year. And so the technique that I used for fitting and prescribing scleral lenses is a little different. Dr. Morrison, on the other hand, what has just every toy at her fingertips and has the most amazing analysis of so many extra details on knowing how to truly modify a lens. But really what we're going to try and argue a little bit is, what do you need? What's important? What's going to give your best patients the best outcome? And like,
You go. And not
where
every,
should
and
you?
yeah, where should you go? And it's kind of an
Yeah.
interesting thing as well in line with that is when thinking about like all kinds of tools. We have our basic, we'll say the traditional artist on the side with the kind of topographer slit lamp. That's typical for a lot of scleral lens fitters, especially if you're just getting started out. On, the other side, there's all kinds of tech, including ocular surface testing, endothelial cell counts, all these different tools that we can use. And so that's kind of, we'll dive in next and kind of to get going on this story.
So we want to start pretty basic. What's the best way to do the initial lens design? So I'm going to go a little bit onto your traditional fitting versus Sheila will talk about tech. So how do you start? If we go to the next slide, Sheila. When it's traditional fitting, there's kind of two big things you need to think about. Number one, your sagittal height and your lens diameter. Where do you start? Whether it's whatever brand you like to work with, what lens diameter and what lens, whether it's sagittal height or base curve, however it's listed in your chart, where do you start? And there's a lot of different techniques, but to be honest, I like to just say don't overthink it, right? There's an empirical recommendation or diagnostic fitting guides that a lot of the lens manufacturers give that are very, very shockingly good. And also a little bit of like clinical wisdom you can apply to your fitting guide, considering which disease process the patient has. So we can give a couple examples, Sheila. And then edge design. This is a big one because we know a lot of eyes require toricity in the landing zone or a toric haptic. Is that necessary? Should you start with that lens or should you start with a spherical toric or spherical haptic? So Sheila, if you go
Thanks
to
for
the
your
next one.
answers to all these questions. So here's your diagnostic fitting guide. So what do you do here in the clinic?
Yeah, so I mean, this is a really easy go-to for someone who's like, I don't know where to start. Sometimes I just say like literally pick a center lens and go for it. But if
I
you
have
want
to say,
something
so
that
I have to call out to Mark Andre, who I'm sure is not listening to this because he's now in retirement mode and doing super fun things. That hits a chord because it would be like, if you don't know what the F, what you're doing, just start in the middle, grab something and put it on the eye.
go, don't let that
Go.
stop you. Stop overthinking it. Pick something in the middle and go. You'll either be too flat, too steep, or just right. Go for the Goldilocks approach. But if you want some numbers to go by, a lot of the companies have different recommendations and they try to make it super easy. This is one of the companies available. They say get your Ks, go for flat K, times it by 100. So in this example, it's 4250, times it times it by 100, and you're going to be a 4250 sag. Find the lens that's closest to that measurement and pop it on. Get started. Don't wait. This is the biggest obstacle, and don't make it something that's a hard hurdle for you.
What about your
There,
HVID and lens diameter? What do you do?
yeah, actually go to the next slide. I want to show you some thoughts. So I have a couple examples of things to consider. With HVID, typically speaking, within each lens brand, you'll kind of find your favorite, like your sweet spot. I don't know about you, Sheila, but I like to stay in the 16, 16 and a half, 16
Yep,
8 range. That's kind of
agreed.
my go-to.
On average.
Um, but like, so for example, I have two different pictures. One is a patient. Let's go with the center picture first. This patient has some significant punctate epithelial erosion. The picture is cropped a little, but it's going across both the cornea and conjunctiva. For a patient like this, let's just guess that they have an HVID of around, 12 and a half. What would you consider for first lens?
So 12 and a half,
Uh,
I probably aim for like minimum 17
yep.
myself.
Aside from just the HVID, what else would make you go a little bigger?
Probably like ocular surface disease. Like if somebody has like is sensitive to dry eye that you want to do something that protects the sclera,
Absolutely.
I would probably go a little larger for ocular surface disease.
Absolutely,
You same?
especially that staining on the conjunctiva extending
Totally.
past beyond the limbus. The
Hmm.
more coverage you get with that scleral lens, it's really hard if someone who has chronic or recalcitrant punctate epithelial erosions,
Yeah.
whether it's on the cornea or beyond, it's really hard to heal that. And so that lens is going to provide them a lot of protection. On the left image, just a real quick picture, if you go back a slide, Sheila, this was a patient with basement membrane dystrophy, very sensitive eyes, recurrent erosions,
Half eyes to
small
fit.
eyes, tough eyes to fit, but they're very
Maria
rewarding. And
Walker.
that's someone actually I would go a little smaller for, at least to start, just because it's a little easier to get the lens in. It as long as the eye is more of a standard shape, it can be an easier transition for someone who's scared to touch their eyes because they're just kind of traumatized from their pain. So, anyways, those are kind of some of my little pearls for
Clinical
considering the disease process. And
versus half
then,
landing.
yeah, so now it's a scleral lens, right? So fitting the sclera is important. And actually, Sheila, you probably can share more than me about what is the percentage of people that actually need a toric haptic versus a spherical lens in a landing
Well,
zone.
it's a pretty high percentage. There's a group called the Scleral Study Group that I was a part of for a number of years, and a lot of the studies that came out of that group really showed that majority of eyes need either toric or asymmetrical, and that's based off of analysis of ocular surface mapping data. And over the last couple of years, I've been hearing some new ideas from different groups in terms of how the data is analyzed, and it's always possible. So what I've learned is that on average, most eyes are not actually spherical. In fact, very few are actually spherical. But the number of eyes that truly would not be okay with a toric landing or something that's, asymmetrical, maybe is a little bit lower than they're a little higher than we thought. And just in terms of how the data is analyzed, I think we'll start seeing studies coming out over the next 3 to 5 years that show different ways of analyzing data that will be able to characterize that shape just a little bit better.
Absolutely. Love that. If you
How
go
do
to
you
the
pick
next
your
slide,
starting lens? Like, what do you do if you're fitting
glad
traditional?
you asked that. Perfect lead into my next slide. A tip that I'd like to give for someone who doesn't use, extra data, if you hit next slide, my tip for starting a lens is actually to start with a spherical haptic lens. So I'm giving an example of an image of a lens that I put on the eye. It's a spherical haptic, so there's no toricity in the haptics. And to me, hit tap one more time, you can see the edge profile a lot easier, and it kind of just makes more sense as you're building your lens if you know everything is spherical, as opposed to like maybe your flat edge is actually in the steep zone, but it still isn't fit right. So then you kind of have to do math to figure out how much do I need to steepen and what do I need to flatten.
Yeah.
So I like as a tip, I always start spherical in my haptic. If anything, maybe I'll put one spherical, one toric, just to see if it's not really obvious what the edge looks like, if a patient is just immediately more comfortable with one or the other. But I think starting spherical, that's a really easy tip so you don't get yourself lost in the mix
I
of
love that. And
understanding.
part of it had a patient in yes today actually. There's -18, pretty regular-ish shape of cornea, high power, high sill, but fairly, we'll say regular. And so the eyes being roughly symmetrical, that's a great opportunity to place a spherical in one eye and a toric on the other, just boom, boom, and just ask them what they feel. Which one looks better? And in this case, what you're looking at in this picture, just to kind of dive in a little bit deeper, when we look at this fluorescein pattern, I have to shout out to Karen Lee, who she is the photographer of these photos, which we didn't credit. Oh, it is in there. Image Karen Lee. Perfect. We cannot forget to credit Karen. She's amazing. And this is actually an against the rules shape sclera, which is kind of a cool case,
Yep.
because on average, more eyes than not are with the rule scleral shape. And we can tell that specifically by looking at, as Roy mentioned, we'll just say let's say this is a spherical shape, a known shape. It's a little bit tight in the superior and the vertical meridian, meaning that that is higher. So that's a flatter, higher meridian, more closer to us. And then steeper falling away from us, if we're looking at the patient, is that the lateral side, nasal and temporal. And so it's really cool to be able to look at things this way. With my patient, when I threw, again, you want to get going with your diagnostic fitting, just, move along. Don't overthink it in the beginning. Pop the lens on immediately. I had him close his eyes, blink a few times. Which one's more comfortable for you? And I didn't actually look at his ocular shape ahead of time because he was very hard to image due to dry eye. We didn't get good images. I just moved on because I was too busy. And he loved the feeling of the toric. And then I imaged him later just for fun myself. And it turns out he has a very with the rule toric sclera. So that would make a lot of sense what he felt. So you can go back and forth both ways, utilizing the techniques that you're describing.
Absolutely. Well, let's talk about tech. Tell me what you do.
So there's today with the advent of all these different tools, and it's not just one that you need to use. Corneal topography is a wonderful starting point just to evaluate. So in our clinic, whenever we get a patient in who is, maybe referred in, or we're thinking about fitting them in specialty, they're referred for sclerals. This is a scleral lecture. We're going to focus on that. But I also question everything. So if I get a case that wants to be fit in a scleral, maybe they found sclerals online, or the doctor that referred them thought that they would be a good scleral patient, what we'll do is comprehensive ocular surface mapping without neglecting to look at the cornea. So on the left-hand side is a quad map that will measure ocular surface, not just on the cornea, but also the whole scleral shape beyond the limbus. And then on your right is an example of a corneal topography with an axial power map on the top and an elevation map on the bottom. The reason I show those two different maps is to highlight the reality that when we're looking at corneal topography that we're used to, axial is curvature. This does not necessarily give me the true picture of exactly what the shape is of that eye that I'm about to place a piece of plastic on. This gives me a map that tells me the power and the curvature. So we'll often flip over to an elevation map of the same eye, and you can see on the bottom, there's a little kind of squiggly kind of line that jumps right up on the left eye on your right-hand side on the elevation map, just highlighting the reality that the difference in the highest and lowest points on that map are very, very great. Now, when I see that in my evaluation in the clinic using tech, using topography, I'll immediately make that decision, or can they wear a corneal lens? Are they a good hybrid candidate? In this case, let's just go straight to sclerals because that height difference is too great between the highest point that's closest to me and the lowest point that's furthest away to me. A lens that lands right on that space will just kind of rock around and not land as well as a scleral would, which just jumps right over it. Now, ocular shape, here's an example, just really quick nutshell. We've got toric, we've got spherical, we've got asymmetrical. And in reality, what we can do today and what I do is we can actually use the scans to digitally design lenses. To kind of back to your kind of the traditional side, I do have to point out that I think this is one of the points that you and I had talked about is that we still never want to throw away diagnostic lenses for power. More times than not, we're going to be putting a lens on the eye in these digitally empirical design cases to make sure if it's our first time seeing them that we have a decent measurement of power. But nonetheless, it's pretty cool what we can do in terms of getting that shape to be really, really amazing right on the first round on those highly irregular eyes. Now, this is an example of, one of the technologies that will measure comprehensive eye shape. And in my flow in the clinic, I will actually have my staff do all the measurements ahead of time, ocular surface mapping, including pachymetry, baseline, all these measurements. And then even before I go in to see the patient, I'm using software that will predict the sagittal height of the eye. And I'll just show you what this looks like. It's just, if you can see the mouse kind of clicking around, it's just click, click, click. And I know bias or choose for this presentation. It's just an example. And basically it will give us the sagittal height of the eye at any given chord. It will select a diagnostic starting lens, gives us the HVID, makes a whole bunch of recommendations. So I'll pull the lens or notify my staff to come and do this for me as I'm walking in to speak with the patient. And as they're cleaning lenses because I have a pretty good idea I'm going to put a hard lens on that day just to assess vision a lot of the time. I'll be spending my time not kind of fiddling around with different lenses. I'll spend my time talking to the patient about their goals, figuring out what their barriers are, and having the staff kind of pull that starting lens that way. So that's how our clinic flow works. And it works for us as well. Now, a little quick summary. So we want to TLDR. So Roya, let's take this away. So what was it? What does that mean
Too
again?
long, didn't read.
Just
So
kidding.
for
I didn't know.
traditional,
I was trying to
for traditional fit, really my biggest tip is don't overthink what lens you want to start with.
love. That's amazing
Um,
tip.
so by the end of my time in Seattle, we actually had a corneal topographer. We had all the fun tools. And I'll be honest, my tech coverage was great, but I was splitting time using our tomographer and our OCT with a large clinic with a lot of other, eye care specialists. So to me, it was hard to incorporate into my clinical flow. Not to say that it couldn't have gotten there, but there are some
That
times
hurdle
where
to
the
get
scan
there.
quality is hard. Well,
Yeah.
even there's just some people that are hard to scan. There's some limitations. Maybe they have really bad scarring, and you're just not getting good data. So not to say that this is not an amazing option and everyone should consider it, but it can't always be relied on. Sometimes you still need to put a lens on. And just like Sheila said, you need a lens oftentimes for a refractive outcome. So if you're putting that lens on, if you can guesstimate close enough, especially for a normalish eye, sometimes it can save you time. But of course, we can argue that chair time could be saved if you just know right away from a software, this is the lens you should start with, and you should make these changes to the edges, right?
I still shoot myself in the foot occasionally. I just did it this week, thinking that I'm going to go ahead and put a patient in a lens that is it's not that it's good or bad, just like, a really steep, proud graft. I'm trying to save the cost a little bit and try them in a lens design that, sometimes you just have to go with what works. Driven freeform is a much faster path to the finish line. And in a practice, depending on kind of the type of patients you see, whether it's dry eye or lots of really irregular eyes, that definitely plays a role in our decision making of what tech that we want to use and when and why. Education is so powerful, using tech to show patients why we're putting them in a certain device and show value. Why do we charge for our services? Why do we recommend a certain thing? And also to differentiate from competitors.
Absolutely. Let's talk about corneal clearance now.
Let's do
So
that.
how do we figure out corneal clearance, whether it's traditional or tech? Going to the next page, the traditional pro tips that I would give. Number one is factor in settling time. Depending on how much time you have with your patients, I usually saw patients within a 20+ minute window. Most of that was spent with my technician. So I might put a lens on, or my technician might have helped put a lens on, but I'm not going to wait 30 minutes for settling. I know and anticipate by a lot of our amazing researchers that we expect around 150 microns of settling. So I'm factoring that into my math as I'm doing my fitting. Also, another pro tip is you can't see less than 80 microns of fluorescein. So if that seems like there's touch, that don't necessarily make a quick judgment. If you're fitting and you need to incorporate more fluorescein, or excuse me, incorporate more sagittal height, you can do that in your ordering. But also, when you have a fit lens, if someone's coming and wearing a lens, you don't necessarily need to, you can figure out if someone has a problematic lens actually by removing the lens and checking for staining. Another pro tip is that if the fit isn't perfect yet, and I like to refer to that more so in the haptic design, you want to check clearance actually when the lens is centered where you want it to be, because it may look really nice decentered, and then when you center the lens, the fit may not be so good anymore. So edge modifications can actually affect sagittal height as well. Those are all things you kind of want to factor in.
How do you do your
This,
slit lamp? Can you give us a few key tips on slit lamp exam in the traditional
yes.
style? So like hit me with the basics.
I'm gonna give you the one, two, threes.
What
This
do you do? The
video,
one, two,
you can
three.
all imagine this video is working right now. But essentially what I'm gonna do is make a skinny parallel pipette. I'm gonna turn the brightness up as much as I can. And I'm gonna go all the way across the cornea. I'm not just paying attention to the central clearance. That is important, of course, but I'm going all the way from limbus to limbus. I'm looking underneath the upper lid and I'm underneath down on the bottom. You want to check everywhere because it's really going to make a difference to the fit. If you go to the next slide, though, Sheila, sometimes we look and we think there's touch, right? This picture looks pretty obvious. There's touch. Let's say this is a patient that came in for follow-up and I'm seeing that. If I take the lens out, that fluorescein is going to tell the story. This patient may have, a very steep cone that is, we don't want to go too big or, have too much clearance. We always want to think about the hypoxia factors that we know can affect the eye, but also not touching is good. That's all we really want is the lens to not touch and obviously have maybe a little wiggle room for fit. What would you do in a situation like this, Sheila? Let's say it was a final fit. Would
This is a
you
final fit, out
change?
of warranty or in warranty?
It's out of warranty.
Oh, sad. Damn. It depends. So out of warranty, what I would do is I would monitor them a little more closely and take the lens off for staining and just make sure.
So
And if
what we did on the right side is
Yeah, and there's no
the lens
staining,
is
so I'd let
down.
him go. I'd let him go with it, and I would just follow them a
Yep.
little more closely every 3 months or something like that and see. So, what about this? What is this beast of the cornea? What's
Yeah,
your
so
analysis
these are
here?
a couple different pictures, all different eyes. Let's start with the easy one on the far right, the two pictures there. That is showing some paralimbal staining, and that could very well have been the staining pattern from the previous picture. If that lens is actually touching at that limbus and causing friction, that's a problem, right? So I don't like seeing any staining at the limbus. I'm going to either go larger in diameter or adjust that zone over the limbus to give that cornea a little more space. As that lens is settling, it's going to be, coming in contact with that limbus. The two pictures on the left, Sheila, tell me what you think of those two pictures. What's going on there? Is the lens too flat? What do you think?
So toxicity. So just to kind of be able to move on, that's something to watch out for when you see staining. It's not that the lens is rubbing necessarily in this case, but sometimes solution toxicity can create that global kind of boggy appearance. So you always want to check with patients and ask kind of what are they using and how are they using it. Now this is a kind of another sort of opposite of what we saw where there wasn't touch. This is lens removal with a slit lamp evaluation of a lens that is a problem. This is a patient that has a neurotrophic cornea, secondary to kind of a botched cataract surgery with a raised L. And so in this case, patient felt nothing. If we're not evaluating the cornea carefully for clearance through the whole thing, this was missed initially because scans were done as a cross section in the middle, and that is just not acceptable. So this is an example of another kind of other thing that you could do traditionally to kind of look to see what's touching, what's not, because usually if there's true touch that's bearing, there's going to be something on the cornea left behind. Now, technology pro tips, kind of similar, couple quick things that I want to share about when we're using technology like OCT, for example, to measure corneal clearance. Don't neglect the mid-periphery. So same as the cross-section that we did with the slit lamp, always look at the mid-periphery and create the same protocol for scans at every visit because we want to be able to kind of compare how that lens relationship is from a new lens to a lens that's a couple years old or, has the lens warped a little bit, flattened, has the cornea changed. And so again, just make sure to do the same thing at every visit and do not neglect, meaning patient with corneal transplant needs not only the edges scanned, which we'll talk about in the edge section, the central cornea clearance, but looking throughout the lens. So I want to show you a couple of quick slides here. This is an example of a patient who you can see some different types of scans that show very different amounts of clearance throughout the cornea. Now, this is a patient with a nodule. And so on the right-hand side, for example, if you take a look at the cornea clearance with the OCT and do, say, a cross-section through the center, both ways, it's a chance you can miss something like this. And so doing a careful scan and hitting the problem spots is really important tip for technology-driven assessments. So here we go. Here's a patient case. Beautiful, looks about 200 microns of clearance, looks good centrally. Drop the mic. No, this is what the mid-periphery looks like if you actually take the time to look at the graft-host interface, and it's not always as good as the center, so you have to measure it. Here's another patient. Patient today of Dr. Chung's, and same thing. So this is, oh, the last one is Dr. Chung's. This one is my patient. They just look so similar in the center, and if you actually take the time to measure the mid-periphery, you can really image and also use these scans where there's obvious excessive limbal and mid-peripheral clearance to teach a patient why we need to make a change. Now, kind of in summary, when we're talking cornea clearance, kind of the tips and tricks. So we want the lenses to settle in both cases. You need 800 microns to see fluorescein, center everything, and perform the same scans at each visit, looking at the entire cornea. Next, we're going to talk about edge lift. So traditionally,
we're going to look at, let's go to the next slide. We have, when you look at the lens, we saw this earlier, but when you assess the edges, you can't just look at the problem, okay? So oftentimes it's so easy just to look at, for instance, the horizontal meridian, and you see in this particular image, oh, it's too flat, right? We need to steepen this edge. Or only look at the vertical meridian and you want to flatten that edge. But you got to think about how that's all going to affect the outcome. You don't want to make two changes at the same time. So look at everything and then decide what do you need to do to make an effective change. If you go to the next slide, I like to do something called the eyelid test, or the lid awareness test. And essentially what you actually can do is sometimes you're not sure, do I have edge lift or not? Oftentimes edge lift is a little bit uncomfortable. Most patients will complain, oh, I'm feeling something up over here. And if there's not discomfort, I often don't change it, especially if the patient's not symptomatic, they're not getting foggy vision, there's no papillae on the upper lid. So take their lid literally at the slit lamp where you think you see edge lift and move the lid past the edge. And then you'll know, do I need to make a steeper edge, or can I leave this as good?
I think this is the most important traditional tip of the whole thing so far is if the patient is happy and it's safe and everything is good, leave it.
Exactly.
Like, leave it.
Exactly. You can argue that a little bit of lens or fluid exchange is probably a little good for the cornea. So,
Love.
don't fix, don't try for perfection every time. That's a huge pearl you learn as you kind of get more expertise in fitting scleral lenses. But understanding your problem is another important thing when it comes to fitting an edge. If you look at these two examples, it looks like a tight edge in both scenarios, but actually it's different. So on the picture on the left, if you go to the next slide, it's actually a tight edge. That very far edge is compressing the
like squishing down and popping up, right?
Exactly. Versus the image on the right actually has a too steep edge. It's like an elbow compression, some people will call it. But if you look at the OCT image, you'll see that it is hitting hard and then lifting.
Love. Now, OCT can also be used to evaluate edges, but the key pearl is do not always rely on OCT for edges. I love my OCT and the tech. OCT images can be a little bit misleading. Conjunctival tissue is very spongy, and so the tissue can kind of give a funny appearance on the OCT. So always best to take it also with a slit lamp evaluation to kind of compare the two sets of data. Make sure you're always taking images in as close to primary gaze as possible. And really good edges should really be, if you're wondering what normal is on the OCT, should be roughly about 1/2 to 2/3 into the tissue of the conj. Now, that's going to vary a little bit. It's not always going to be exactly the same. And one of the things you see here on number 2, which is the superior, that you might notice a few little bubbles. So this would be kind of what we would see on the OCT if we were imaging Roya's patient that had air bubbles kind of getting in on those side meridians where the edge was a little bit loose, we'll say. And you can actually see that the OCT edge does look like it's kind of like floating on the top. It's not really settling in. So that all kind of makes sense, but we still would want to partner that with a slit lamp. Now, this is a really cool part of testing that we wanted to share with you that's kind of tradition and tech, both mixed together. So after our OCT imaging, we recommend in our clinic, and what I do is we always will then go back and say, look with a slit lamp as well. So it's something that we do with our technology and add fluorescein to the outside of the lens using a slit lamp to be able to look to see where there's bleed through. Roya, do you have anything to add to this slide? Anything that you had in mind that you wanted to share?
Nothing really except the fact that like putting fluorescein on can give you answers too. If you're confused what's going on, especially after lens has been settled or patients come in with their lenses, I love seeing a patient wearing their lenses. Put some fluorescein on the surface and it can help explain a lot of things. So if
Love.
you go to the summary slide, the big thing is utilize simple tests. I mean, even when you have your technology, patient can often tell you what needs to be changed. And if they're not complaining and there's not a problem, you don't need to change it.
Love.
That's my tip.
This pearl of the day or a cell pod if we were on the podcast. So what about
Exactly.
that question, like my vision gets foggy? So this is where like, do we use technology? Do we use traditional tools? Vision foggy, getting foggy can be many different things, and it's usually categorized into three basic ideas, I would say, or we would say. One would be the fogging that comes from something being on the lens. So non-wetting, debris stuck on the lens that's not really operating smoothly with the interaction of that plastic and the tears and whatever solutions it's exposed to. Next would be true fog underneath the lens. So debris that gets under the lens or true midday fog itself after wearing a lens on the eye. And essentially those patients will end up with kind of this sort of blurry vision that comes from stuff underneath the lens. The third part of foggy vision that we have to differentiate is cornea edema, and that can cause blurry vision as well. Now we have our traditional way of looking at things with the slit lamp and our tech side. So Roya, let's go through some of the things that you think are the most important for technology or for traditional diagnostics when solving the problem of fogging.
When it comes to traditional, half of your answer is going to come from your chief complaint. So asking how long it happens, does it happen immediately, and is this always happening, I think is important. If you go to the next slide, um, seeing what layer is affected behind the slit lamp is also incredibly helpful. I actually like patients to have worn their lenses worn them for a couple hours because usually it's going to
Totally.
show right away what's going on. If you look at the left, that's obviously the surface is wetting poorly. Second is going to be your tear reserve. And third, you can kind of see this if you look really closely, but this patient's having corneal edema in his graft. So obviously that's causing an issue. The next picture, you'll see we showed this just earlier, this video, so I'm not going to go through that again. But on the next slide, Sheila, is the fluorescein getting under, doing the fluorescein test. If your fluorescein is getting under, it's telling you you probably need to make an adjustment to the edge. And lastly, the next slide, like I mentioned, you can see on the right the edema in the cornea, and you can see on the left some signs of hypoxia or neovascularization into the cornea. So this is telling us something about the lens perhaps is taxing the cornea even more than necessary. So could you start utilizing technology to figure out more? Yes, but you already almost had your answer. Something's going on that needs an adjustment. Sheila, how to use tech then?
So density can be seen on the OCT. So we can do a comparison for fogging using like an AM/PM where we take an image looking at a cross section underneath the lens right when it's applied, and then later in the day we can see density. And tear segment photography is something that we haven't really kind of keyed on, and it is such an important measurement, and it is a technological benefit not only to use your slit lamp but to image what you're seeing because it keeps a permanent record and also acts as either a baseline to prove that we're not creating harm or also demonstrate what changes are happening in the eye. And
A
so
great
then
point about the baseline.
finally, yeah, and then the other pearl is don't forget about dry eye tech. Is at the application point, fluid's nice and clear. Anything that shows up with more density or particles is going to be kind of have that hyperfluorescence on the OCT. And then usually you'll see it in the slit lamp as well, kind of matched together. Now, these are some cool videos that I wanted to kind of throw another spin on technology into this lecture because technology in the dry eye clinic has become an absolute mainstay for us when we're optimizing outcomes with contact lens patients, especially scleral lens patients, because their tears the tears have to be smooth and they have to be behaving for the eye to actually successfully wear the contact lens and have good vision.
The
I
plastic,
want to
right?
show, yeah, I want to show off. Like, what do we do with tech? Well, we operate all kinds of crazy dry eye treatments with that for them. On the left-hand side is a patient of ours prior to having BlephX and IPL and radio frequency. On the right is after dry eye treatments with kind of a high level of technology. You can see that she's not blinking all the way, but the tears are much, much better. And the patient overall had a much better experience with her contact lenses. So this is Dr. Wincy Chung's patient in the clinic. So kind of in summary, so traditionally, We want to isolate the fog. Where's the fog coming from? Is this fog that comes from the front surface, back surface? Is it underneath? And as far as the tech side, there's a whole bunch of things that we can do to not just mitigate it, to kind of solve the problem by not ignoring the ocular surface, which I know technological folks like you also pay a lot of attention to the ocular surface. But taking baseline scans and pictures are one way that we can really help to properly evaluate and record how corneas change. Do they have swelling? Do they not? And where is the fog actually coming from?
Totally. And just to add on to that really quickly, having that prior discussion or even prior photos can help you and the patient have a relationship in regards to the fact that they trust that this isn't damaging me. This is something that you alluded to, especially maybe their ocular surface disease being an issue. And so when they come back, in 3 months saying, Doc, my lenses aren't wetting well, or I'm getting really blurry vision, you can say, okay, I'm glad you got good vision potential now, but we need to treat your dry eye. Otherwise, you're not going to have that stability that you're looking for. And on that same note, talking about best corrected vision. So patients not having the best corrected vision, let's kind of talk about two different approaches for how we get best corrected vision. So going to the first topic, when we talk about a gas permeable lens material, we know conventional lenses in general mask about 65% of higher order aberrations, but they are limited to spherocylindrical correction, right? Aside from being able to incorporate both of those powers in most scleral lenses, if you go to the next slide, Sheila, I think that one of the pearls I would say is learning to optimize your fit hugely can impact your optics. So in this image, you'll see that this lens, they have dots to kind of show the centration pattern. You can see this lens is decentered inferior temporally, which is pretty common. And for the fit of that lens, to the health of the eye, that's not that big of a deal. But it is a big deal when it comes to the actual vision. If you go to the next slide, Sheila, you'll show that the optics are actually not lined up over the visual axis. And so this patient's best corrected vision potential is actually decreased. I have a really, really cool case actually that we worked with. She was fit in conventional lenses. She was comfortable with them, but her best corrected vision was around 20/40. We actually refit her into an impression-based lens because she heard that her vision would be better. And to be honest, I was kind of like, I don't know if it's going to get that much better. She had cataracts. She had some other issues. She actually was seeing 20/25 with essentially the same power, but in the impression-based lens. And that is truly because that lens is such a nice glove fit. It's centering those optics and providing a much more centered fit and centered visual prescription. So anyways, she was very happy with that option and subjectively very happy. So aside from the spherocylindrical correction, there's also options for binocular vision improvement, and that's including prism correction. But the most important thing, if you're going to try and do anything fancy with a scleral lens, is you need to make sure you have good centration and good stability. So toric haptics of some sort or something to ensure that your lens is well centered.
Now, on the tech side, 2020 unhappy patients we see today really trending in the expansion of technology is higher order aberration correction. I want everybody to think about doing topography over contact lenses to highlight where the optic is relative to the visual axis. And technology, as Roya kind of alluded to, is also a benefit in creating lens stability with customized shapes that are really that lock and key so that we can support the weight and the position of high-level optics, including prism and HOA correction. Here's an example of HOA. It's pretty cool. We look at patients in the clinic and, when it comes to aberration, the answer to that is yes, we absolutely should, because a patient population that has kind of not the largest population that we serve. It is a subpopulation of our overall group of contact lens patients that we would consider sclerals. But usually the patients that suffer from higher order aberration, I don't know about you, Roya, they are often desperate for something different, like they've been trying other things. They're really frustrated with the procedures. And so this is just an example of before and after plots and what technology is capable of when we are able to place higher order aberration correction into contact lenses. So in closing, we've seen many, many cases, and this is just a very quick example, a patient of ours that we combine technology, and that's kind of the fun part of where we're at today. And not just, technology using like a scanned lens, but using digital lenses design, creating the shape, using all of the traditional tools to really do a very good job in the clinic of documenting things. You can see anterior segment photography here, leading all the way into using digital designs to put higher order aberration correction into patients that would have otherwise not been able to have as high of quality outcomes. Now, in conclusion, Roy and I strongly feel that there are multiple ways to reach the finish. We've all kind of heard this story before and seen that finish line because it really is true and continues to be. And so when we consider kind of tech versus tradition, some of the other things that we look at include, what is the chair time needed? So if you're thinking about putting technology in your office, or maybe you're the type that you want to stick with your slit lamp, that's fine. But whenever you're thinking of what do you want to spend your time using to fit scleral lenses, think about chair time. Think about, does it pay off to fit a certain style for you in your particular style that results in fewer office visits and fewer remakes? The
Or
return on
staff,
investment is
right?
important.
Staff is a
Yeah,
hard thing too.
yeah, for sure. So the technology and art of fitting both are crucial, and in conclusion, technology and tradition are better together.